Hello, everyone. This is Dr. Cross, and this week I will be reviewing schizophrenia as well as other psychotic disorders. The main types of clinical types of disorder that we'll be covering in this presentation is delusional disorder, brief psychotic disorder, schizo schizophreniform, there's a typo there, schizophrenia, and schizoaffective disorder. Again, to repeat, the main clinical types are delusional disorder, brief psychotic disorder. This next one should be schizophreniform, spelled schizophreniform, schizophrenia, and schizoaffective disorder. Key features of psychotic disorders include delusions, or key features specifically with delusions are fixed beliefs that are not agreeable to change. So when you're thinking about the key features of someone who's presenting with delusions, they have very set and fixed beliefs about any type of thing, whether it's somebody following them, whether it's beliefs that someone is trying to harm them or hurt them, whatever the form that these beliefs may take, they tend to be very set and it's very hard to convince them otherwise. So, not very easily changed beliefs. We also think of persecutory delusions, which are the beliefs in one person will be harmed or harassed. Again, the belief that a person will be harmed or harassed is what we think of when we talk about persecutory delusions. Grandiose delusions are beliefs or the belief that one person or a person has an exceptional ability. So again, beliefs that someone has exceptional abilities, can read somebody else's mind, perhaps. They're able to control people's thought, would be an example of an exceptional belief that will fall under a grandiose delusion. We also have nihilistic delusion, and that's a belief that a catastrophe will occur. Again, please be mindful that these are very set beliefs or thoughts, patterns of thinking with people who present with delusions. And it's not really easy at all to get them to change their mind about these beliefs. So, again, nihilistic delusions are a belief that a catastrophe will occur. We also have somatic delusions. When you think about somatic delusions, there are beliefs about a health or organ function problems. Sometimes they can present as gastrointestinal problems. Pains oftentimes are also involved in somatic delusions. When we think about the somatic delusions, we are talking about some type of belief that pertains to the body. And these are oftentimes are rare, but we do see them at times with clients. They're fixed false beliefs, and it also appears to be associated with bodily functions, um, and the belief that there's something grossly abnormal about how their body is functioning. Um, Most doctors tend to diagnose this with clients when patients present with these type of bodily challenges or concerns, and several tests are done to rule out a medical cause of these symptoms. Um, and then the doctor may start to suspect that these may be psychiatric symptoms, and then refer a client or a patient to see outpatient mental health or therapy. Again, this doesn't is considered one of the rare um, delusions, but we see it often. And oftentimes they can also mimic other type of medical problems. And so that's why it's very important that a lot of the medical problems or the medical symptoms that a client may be presenting with is ruled out, because you want to make sure that it is not a medical a component related to the concerns of their symptoms. But again, pain is a common delusion that may present itself, and that pain can occur in any part of the body, not limited to arms, legs, um, other types of extremities. Also, it could be migraines, chest pains, other type of somatic beliefs of symptoms that may not occur. We also have a category called bizarre delusions, which are implausible and not understandable, and unbizarre, which are plausible and not understandable concerns. An example of a bizarre delusion would be if someone thinking an alien is in their head, or that they've been cloned by aliens, or maybe a belief that something in the TV is controlling your thoughts and your behavior. That would be an example of a bizarre delusion. An unbizarre delusion is something that could potentially be plausible and that could happen, but based on the context and the circumstances, it's not understandable why that would happen. For instance, this may be a delusion that the police is following you, or the FBI is recording your phone conversations. Even though that is possible, it's not bizarre. We know that it is possible to have your phone tapped. In probing the client more, they have done nothing wrong. There will be no reason to have their phone tapped, for instance. And so in that instance, it will be considered an unbizarre delusion. Some of the key features of hallucination includes perceptions or feelings that occur without external stimulus. These perceptions are often vivid, clear, and detailed, oftentimes involuntary, and they occur with any sense, but primarily auditory. And when we talk about the senses, patients can present saying they feel like heat, a warmth, as if somebody put an iron on their hand, a warm iron or a hot iron. Some patients that have perceptions feel like little needles are being put in their skin, as an example. But again, these have to do with perception and things that feel like they're actually happening to that person. And we can rule out any external stimulus that would cause those feelings, or even internal, such as medication. Again, to the client, the perceptions that they have are very clear and vivid and or detailed. And again, they are oftentimes unwanted perceptions, so they're involuntary. And again, when you think about how these hallucinations can occur, please consider all the senses. This is vision, hearing, think, taste, smells, any type of perception that client may have can fall under a hallucination. Another key feature of a psychotic disorder or psychotic symptoms include disorganized thinking. So when you're trying to determine whether somebody has disorganized thinking, you want to understand how they're talking to you. So you can tell whether they have disorganized thinking pattern by their speech. Are they slurring? Are they stuttering? Are they repetitive speaking patterns? Unclear in tone? Um, think of how somebody is talking and any abnormal behavior related to their speech. And this will clue you into to potentially some disorganized thinking patterns. Switching topics very rapidly, very frequently. Um, Not in terms of someone speaking fast and then, really excited about an event and they're sharing this event with you, and so their pace becomes a little quickened, or, then they jump to tell you the next thing and the next thing because they're excited to share. We're talking about random switching of topics that oftentimes do not make sense. Somebody can be talking to you about the weather outside, and then switch to talking about their mother, then switch about talking about flying airplanes, and then switch about talking about animals and pets and do you like them. Again, a rapid change in multiple topics that seem to have no linear or logical pattern in terms of the switching of the topics. Also, when somebody is having disorganized thinking, they're unable to answer direct questions or answers not related to the question. So you ask them a question, what is your birthday? And they may respond to you such as, oh, my mom is very beautiful. Or what is your name? I have three brothers. Something that's not related to the question that you ask. Um, Sometimes when you're doing a mental status exam for somebody who have disorganized thinking, you want to make sure that they are oriented to time, place, and space. So sometimes they'll ask basic questions like, what is your name? What is today's date? What is the day of the week? Where are you located now? And sometimes if somebody has disorganized thinking patterns, they cannot answer those questions accurately. Um, Also, their thinking and their speech simultaneously will impair communication. So thinking about how you're gathering information from that person. Are they understanding the messages, the verbal messages that you're sending them, and are they able to respond back verbally and or communicate in a way that you're sharing communication clearly? So if their thinking or their speech is impaired, that will convey in that communication. So their thinking will demonstrate an impairment in communication, and how are they talking to you will also impair communication, and their ability to understand you when you're talking to them is also impaired. This is some of the things that we think about when we're thinking about disorganized thinking. Another key feature of psychotic disorders is grossly disorganized or abnormal behavior. Catatonia is one descriptor. And when we think about catatonia, we're really thinking about abnormality of movement and behavior. And it's always consistent with a disturbed mental state. We think about repetitive or purposeless overactivity. We think about resistance to passive movement. We also think of negativism when we think about it, but it's a decreased response to environmental stimuli. It has an abnormal behavioral presentation, and it can range from a series of abnormal behaviors. It could be silliness to extreme agitation. And oftentimes these disorganized or abnormal behavior interfere with activities of daily living or goal-oriented behavior. And so doing things like going to work every day, cooking, preparing meals, engaging in quiet time or with your family, or other type of pleasurable activities with your family, the way these disorganized behavior patterns or abnormal behavior patterns oftentimes impairs those type of interactions. So again, when you're thinking about catatonic behavior or catatonia, decreased reactivity to environment, resistance to instructions, think about rigid, inappropriate posture, and lack of verbal motor responses. It can be a lack of verbal motor responsive or excessive responses to stimuli or an event. When we're talking about psychotic disorders, one term that you may hear often is negative symptoms, which is oftentimes associated with schizophrenia. But when we're talking about negative symptoms, we're talking about diminished emotional expression, a flat affect, if you will, expressionless in facial expression. It can be expressionless in eye contact, expressionless in speech, very flat, monotone speech. We also think of other characteristics that are important when we're thinking about negative symptoms. Other terms you will hear is avolition, which is a decrease in purposeful, motivated, self-initiated activities. Algolia, diminished speech. I'm so sorry for that mispronunciation. That's alogia, which is diminished speech. Alogia, and that is a typo. That is Alogi, alogia. I'm sorry about that. We also want to think of how somebody's asocial, a lack of interest in social interactions, or asociality. You also want to think of anhedonia. When we're talking about anhedonia, we're talking about decreased ability to experience pleasure from positive stimuli. Again, I apologize for the typo in this slide. This is a quick YouTube video that goes over some of the key psychotic disorders. Please take your time to review it. The actual PowerPoint is uploaded to Blackboard, and you should be able to click on this and be able to watch the video. It's about 13 to 15 minutes long, but again, it is to supplement your understanding of the key psychotic disorders that are identified in the DSM-5. Even though this is a brief overview with some of the key features, symptoms, and some terms commonly used in psychotic disorders, this video will also give you some more detail specifically on the these disorders. It is important to know this information and see if you can utilize it anywhere during this course and if it applies to any of the course materials. Thank you and have a good day.